Open it up for sort of a discussion, interactive dialogue. In this to my chest. Discussion, interactive dialogue with both Dr. Cicero and Dr. Williams, who I'll introduce towards the end of the presentation for questions and answers from the audience, get some feedback and some reactions. So, real quick introduction about Dr. Cicero. Dr. David Cicero is an assistant professor at the University of Hawaii Manoa, and he is the program director for OnTrack Hawaii. He is originally from Louisville, Kentucky. He earned his bachelor's degree in psychology from the University of Virginia and his PhD in psychology in clinical and quantitative psychology from the University of Missouri. He completed his clinical internship training at the University of Maryland, Baltimore, where he worked in the first episode clinic at the Maryland Psychiatric Research Center. He has been an assistant professor at UH since 2012, and his research focuses on the assessment and treatment of premorbid, prodromal, and first episode psychosis. So welcome, Dr. Cicero.
Hey, thank you everyone for inviting me to talk today. I'm excited to be here and to talk to you guys about the program that we're developing. And so today I'm going to talk about this first episode clinic that we're planning to open in the near future, ideally sometime later this summer. And to give you a little bit of background before I get into it about where this idea comes from and how we're developing the clinic, there was a large study through the National Institute of Mental Health called Recovery After Initial Schizophrenia Episode, or RAISE, looking at whether specialized treatment for people in the first episode of psychosis, so people who had an onset of psychosis within the last 1 or 2 years, whether specialty services for those folks can actually improve outcome long term. And as part of that, are starting to kind of roll out this model throughout the country, and we're one of the sites that is going to be doing this coordinated specialty care clinic that I'm going to be talking about. And as I mentioned, we haven't actually opened the clinic yet, so I don't have really a lot of data to talk about how things are going or anything like that, or really even any kind of anecdotes or anything of that nature at this point. I'm going to talk a lot about how we made the decisions that we made when we were designing the clinic and coming to making decisions about how we're going to provide care to young people with psychosis. So I wanted to just start off by going through what the agenda is going to be. So I'm going to start off by talking about some of the research that has been done, and mostly on the mainland, looking at what the rationale is for early intervention, why people think it's so important to kind of get people early when they first develop psychosis, and how that might improve long-term outcomes. And then I'm going to talk a lot about what our specific plan here in Hawaii is to implement this clinic. So I'm going to talk a lot about what our specific decisions that we made were, why we made those decisions, and how we're kind of coming to the point now where we're on the verge of being ready to open this clinic. Then I'm going to talk a little bit about the recovery model, and I'm sure everyone in this room is familiar with the recovery model, but I'm going to talk about how that applies specifically to first episode psychosis, and a little bit about why it's so important for first episode psychosis in particular. And then finally, I'm going to talk about the coordinated specialty care model and these different aspects of the model, and how we're going to be using that and how we're going to be implementing that in our first episode clinic. But before I get started talking about the rationale for early intervention, I want to show a quick video of someone who has been through one of these programs talking about what his experiences were like. Getting the sound to work. I can try.
Hi, my name is Ryan. I'm 34 years old. I work full-time as a civil rights advocate for individuals with mental health disabilities in the state's psychiatric hospital. I recently graduated with a master's degree. I have a drive a nice automobile. I'm single and enjoy dating.
That was a very bad idea.
Today I'd like to talk to you about
Speaker lost.
to have my student ID taken. Overweight, disheveled, poorly groomed, and the thing that strikes me most about this picture is like in my eyes, I can see, I can feel what it was like back then. I can see the hopelessness, sort of despair, in the picture. I definitely wasn't happy. On many days, I sort of wished that life would just go away, that I would.
Yeah, for some reason the video is on that screen, but we can't get it on this screen. So, can we turn that card a little bit?
I can see it when folks in the back can't see.
Yeah, maybe we just turn the card a little bit.
I don't get the video on the screen over here. That's fine.
Yeah, it's just a couple minute video. It's just as good as anything with that.
Hi, my name is Ryan. I'm 34 years old. I work full-time as a civil rights advocate for individuals with mental health disabilities in a state psychiatric hospital. I recently graduated with a master's degree. I happen to drive a nice automobile. I'm single, enjoy dating, and I'm also in recovery from a form of schizophrenia. Today I'd like to talk to you about how I returned to school. This is a picture of me when I showed up on the first day of classes to have my student ID taken. I'm overweight, disheveled, poorly groomed, and the thing that strikes me most about this picture is like in my eyes, I can see, I can feel what it was like back then. I can see the hopelessness, sort of despair, in the picture. I definitely wasn't happy. On many days, I sort of wished that life would just go away, that I were dead. It was too painful. One of my main fears was that I would never be able to work. This process of going to school is futile, being a person with major mental disorder, to actually go through this process of going back to school. But I made the decision that I was going to go and study what I wanted to study and pursue my own education, actually, to pursue knowledge for knowledge's sake, despite the fact that I believed that I couldn't work. In the midst of that 7 years that I was in college, I was hospitalized at my most ill moment. I had teachers that were very supportive and allowed me to make up the work. And I was able to take incompletes for those semesters. The support of my family, friends, and my professors was enough when I was hospitalized to allow me to believe that that wasn't the end of the road. The stress of school never put me in the hospital. I'd say the stress of believing I couldn't achieve at school because I'm a person with a mental illness probably was more stressing to me than the stress of finals and final papers and things like that. I didn't think I was able to work, and so I didn't. It was sort of a self-fulfilling prophecy. After I finished my bachelor's degree, I worked successfully for a year before I started a master's program, and I actually completed the master's program in 2.5 years, which was the standard time as opposed to the extra length it took for me to finish the bachelor's degree. And I worked full-time and went to school full-time at the master's level and completed that in a timely fashion. From my experience, I guess I'd encourage anyone to go back to school who's thinking about it. It's such a crucial aspect of my recovery that I think education can be an arena where anyone can sort of discover who they are, discover what they're passionate about. I'd say through the process of education, we sort of become more ourselves by learning what we're able to do. I guess I didn't know who or what I could be until I started learning exactly what I could do in the world and then doing it.
don't have any consumers in our program yet, I wanted to show just a brief video of what someone's experience with this program was like. And one of the things I want to highlight from that video is what he talked about the importance of going back to school and going to work. And that's really one of the major tenets of the program. And we're going to talk about, when we get to the coordinated specialty care model, I'm going to talk about supported education and employment and what a big part of our model that's going to be. And we're really going to be encouraging people to go back to school or to continue in school, because a lot of our clients will be currently in school, or to get a job, whatever it is that is important to that person, really trying to help them achieve their goals. So moving on to the rationale of early intervention. So some research suggests that there's really an under-treatment of mental disorders in youth, so in young people, and that's especially prevalent in people with a psychotic illness, that they're not getting the treatment that they need. And one of the things that the research has shown repeatedly again and again and again is that the longer someone has of having psychosis without getting appropriate treatment, or duration of untreated psychosis, the worse the prognosis tends to be. And there's a lot of evidence that suggests that if we can get people into services quicker, get them appropriate treatment, which is typically an antipsychotic medication and some of the supportive therapy that we're going to be talking about later today, that people tend to do better in the long term. So just to show some numbers on what this looks like for prevalence of mental disorders and then the service utilization. So if you look here, you can see that young people had the highest levels of mental disorders in this study, and that also had one of the lowest levels of service use. And so what I really want to highlight here is this gap in between the number of people who actually have a mental disorder and then the number of people who are getting services for that. So this suggests that, with the limited resources that we have of trying to figure out how we're going to best use those resources, it really makes sense to target young people. As I'm sure most of the people in this room would agree with, it can be really helpful to try to get younger people to get services before they become in a situation where they might have a chronic problem that is more difficult to treat at that point. And similarly, if you look at the disease burden across age, you can see that in younger people, we're going to be talking a lot today about people between the ages of 15 and 24, or 15 and 25. So if you look at these people in this age range, most of the disease-related health burdens that they have is related to mental illness. So if you look older as people age, it tends to be more physical problems, more cancers, cardiovascular problems and things like that. But when we're talking about young people, talking about adolescents and early adults, we're really talking about problems that people are having with mental disorders. So this brings us to the question of where should we be intervening if we want to take this early intervention approach? Should we be intervening after someone already has psychosis or before psychosis? So we tend to think about schizophrenia or psychotic spectrum disorders having three different phases. The first is the prodromal, the premorbid phase, where it's the period of time between birth and when an individual starts to actually experience symptoms. The next phase is the prodromal phase, where people are starting to experience symptoms, but they're not full-blown delusions and hallucinations. They're not kind of actively fully psychotic. And then finally, there's early psychosis, or the active phase of the illness. And so what we're doing with this clinic and what the RAISE project that we're basing the clinic on did was they focused on this phase, so the early psychosis phase. And one of the main reasons for this is that there are limited resources, and thinking about who needs these resources the most. And you can make a strong argument that it's people who already have psychosis and are the most severe at this point. And one downside of trying to intervene earlier is that you're always going to have false positives. So you're always going to have people, if you intervene in the prodromal phase, people who weren't going to develop full psychosis. So people who, regardless of whether they got this treatment, were going to turn out to be relatively okay or to not have a psychotic spectrum disorder at least. So I've spoken with many of you in this room throughout the couple years that I've been in Hawaii about some of my research that's focused on trying to fine-tune instruments in these phases, in the prodromal phase, trying to see if we can tweak our instruments that we use to assess psychosis risk to better assess people, particularly people here in Hawaii. So this is the model of psychosis that we're using for early intervention. So the theory is that, and this is supported by data, is that if you think about people's global functioning during their premorbid and prodromal phase, that they tend to have kind of a dramatic decrease in functioning as they develop psychosis. So as they're fully psychotic, having difficulties with school, difficulties with relationships, things like that, their functioning really goes down. And the idea of early intervention is that if we catch people before they get too far down, that there's less of kind of a hill to climb to get back up to the place that they were. And some research suggests that it can be very difficult for people to get the whole way back up to where they were in terms of global functioning. And so the idea, again, is to try to catch people as close as we can to this period after the prodrome and when they're in kind of a fully psychotic state. And again, that's thinking about this as the duration of untreated psychosis. So to talk a little bit more about duration of untreated psychosis, this is a period of time between the onset of psychotic symptoms and the initiation of appropriate treatment. And so appropriate treatment in a lot of these cases is an antipsychotic medication. It can also be coordinated specialty care clinics like what we're doing. And there have been several different meta-analyses that have found pretty strong evidence that the longer someone is in this psychotic state without getting treatment, the worse they're going to do in the long run. And there are at least two different potential mechanisms for this. One is the active morbid hypothesis. And so this idea is that being psychotic actually damages the brain and actually causes biological changes that make people function worse later on in life. Alternatively, there's a psychosocial hypothesis which suggests that the longer people are away from functioning well, the more difficult it's going to be to get back to where they were. So if we go back to the story of Ryan that we talked about at the very beginning of the video, you could see this with his case in that he was in school and then developed psychosis and was having, had to get back to school, had to get back to that functioning. So potentially, if he had been in that situation longer, he may have had more difficulty with relationships, more difficulty with school, and it would have been more difficult in kind of this psychosocial, toxic way to get back to where he was. There's also been a lot of research on looking at how long people typically have untreated psychosis. And this is a meta-analysis looking at several different studies. You can see that many of these, this is the 1 year line, so a lot of people experience psychosis for a year or longer before they get any kind of adequate treatment. And I've mentioned that there's some evidence that suggests that the longer people are psychotic without appropriate treatment, the worse their prognosis tends to be. So this was a study that looked at how long people had been psychotic before they got appropriate treatment and how they were doing at 12 weeks, at 24 weeks, and then at a year after getting that appropriate treatment. So this y-axis here is the percentage of people who are responding to treatment or are achieving remission in each of these categories. Right? So you can see that at 12 weeks, the people who had only had a duration of untreated psychosis for 10 weeks had the highest percentage of people that were in remission from psychosis. And this continued at also 24 weeks and 52 weeks as well. And if you look closer at this, you can see that it's kind of a dose-response pattern here, right? In that the longer people were had psychosis without treatment, the worse they were doing at each of these time points, which suggests that this can have a lasting impact on the course of someone's illness, how long they're not getting treatment. So now that we've laid out our plan for, or the rationale for early intervention and what kind of motivates a lot of these theories, I want to talk a little bit about what we're planning to do in Hawaii and how we're planning to implement the coordinated specialty care model. So the first kind of decision we had to make, and this is a new slide because we just finished working on this logo, but the first thing we had to do is figure out what we wanted to call the clinic. And that probably sounds like a small decision, but it actually has a big impact on the way that we're going to implement the clinic and how we're going to describe it to people. And the two major trials that were done through the NIMH, one was called OnTrack USA, and the idea being that they're trying to keep people on track in work and school and relationships. And the other was a Navigate model. So they were talking about helping people to navigate these kind of adolescent, emerging adulthood years. And one of the things that you'll notice that's not in the title is anything about psychosis. So we're not calling this a first episode psychosis clinic when we're out in the community talking to people about the services that we're offering, when we're talking to potential consumers and their families. We're going to refer to this as OnTrack Hawaii. So our plan is to implement a full coordinated specialty care model, and I'm going to talk about the 5 different pieces of the coordinated specialty care model in just a minute. And we're going to run this out of the Center for Cognitive Behavioral Therapy at the University of Hawaii. And I'm sure most people in this room are familiar with the Center for Cognitive Behavioral Therapy. And I'm going to talk a little bit more about how we're going to fit in with the structure there as well. So we're partnering with the Child and Adolescent Mental Health Division, of course, and also the Adult Mental Health Division in the University of Hawaii Department of Psychiatry. Our original plan is to start seeing clients about a month from now. So we're still finalizing a lot of details, so it might be a more realistic date, might be later on in the summer or early in the fall, but we're hoping to have this up and running and fully functional very soon. And I'll definitely let everyone know when we're ready to start accepting referrals. So this is the Center for Cognitive Behavioral Therapy, and this is the view from the front door to the clinic. And I just wanted to show this because I think it's really important when we're talking about early psychosis and talking about treating young people that we consider the setting where we're going to be delivering these services. So in talking to people who have developed clinics at other places, they've talked about the challenges of kind of incorporating this into existing clinics, specifically if that clinic is something that's designed for people with chronic schizophrenia. So you can imagine if you're an 18-year-old or a 17-year-old and you're coming into a clinic and seeing someone who's maybe 30 years down the road and has had schizophrenia for 30 years, then potentially that could be a somewhat depressing experience, right? And we're hoping that having this set at the University of Hawaii, where there are a lot of other young people around, and we're a really bright and kind of welcome and warm environment. We've managed to get an extra room at the Center for Cognitive Behavioral Therapy that we're going to use specifically for this clinic, and I think it's going to be a really good setting for that. So some of you may know that the Center for Cognitive Behavioral Therapy had 2 programs, and now we're adding a 3rd program now. There's the Child Division, which is run by Dr. Nakamura and Dr. Miller, who I'm sure everyone knows, and also the Eating Disorder Clinic, which Kelly Vatuzik supervises, and then we're going to now have the first episode Psychosis Clinic, OnTrack Hawaii. So after kind of figuring out where we're going to have this clinic and what we're going to call the clinic, the next thing was to figure out what the need for this type of clinic is in Hawaii, and how we might meet that need. So we started with the 2010 census, so the most recent census of people in Hawaii, and looked at the entire state of Hawaii. And there was about 1.4 million people in Hawaii in the 2010 census. And if we use kind of a conservative incidence rate for the development of schizophrenia or the development of psychosis, it's about 0.03%. So each year we can expect about 0.03% of the population to develop schizophrenia. And that would translate into 418 people in developing psychosis annually in the state of Hawaii, which is a lot of people, right? And way more people than we can offer services to in a clinic. So we thought about how to kind of narrow that down a little bit. And we made the decision to start with just Honolulu County, so just people on Oahu. And I'll talk a little bit in a minute about the reasons for limiting this to island of Oahu at this point instead of including the outer islands. But we also wanted to figure out what the age range should be. So there's nothing specific about the early intervention services that would suggest that you have to limit it by age, right? So someone can develop schizophrenia later on in life. It just so happens that the majority of people who develop it do develop it in late adolescence, early adulthood. So we made the decision to limit it to people between the ages of 15 and 24, in part based on the thinking that we know that earlier age of onset tends to relate to worse prognosis as well. So potentially these are the people who would need this type of service the most. And in 2010, in the census, there were 136,000 roughly 136,000 people between the ages of 15 and 24. So if we apply that same incidence rate, which again is a conservative incidence rate, it might be a little bit higher than that, 0.03%, that translates to 41 people who we would expect to meet this age range and develop psychosis in Honolulu County, which is still a lot of people for a clinic the size that we're proposing. So I wanted to talk a little bit about the current treatment for people with early psychosis in Hawaii. So currently there are, to my knowledge, there are no specialty clinics like we're proposing to develop in Hawaii, but people are getting treatment for early psychosis. They're just not getting it in a coordinated specialty care model, they're getting it in other ways. So if you look at the 2014 CAMD book of all the services provided, you'll find that 2.6% or 39 people within the CAMD system already have a diagnosis, a primary diagnosis of a psychotic spectrum disorder. So we know that there are a lot of adolescents out there who would fit this category and would need these services. If you further broaden that to having a psychotic spectrum disorder as any diagnosis, then that number jumps to 3.2%, and we're talking about 47 people, again, currently enrolled in the system. So there are probably other children and adolescents that have psychosis that haven't made it into services yet. And we would expect that there would be many, many more of these folks in the adult mental health division in that age range of 18 to 24 who would also qualify for these services. And some of you, or maybe all of you, will remember Jason Schiffman, who was here years ago. I wanted to just look at one of his studies that he published in 2006, looking at what kinds of services people with psychotic spectrum disorders tended to receive in CAMD system in comparison to other non-spectrum youth who are getting services. And the main thing I want to point out here is that a higher percentage of these children and adolescents were getting the more intensive services, the intensive home and community services, which is suggesting that these individuals are using more of the resources, as you would probably expect, because they tend to have more severe diagnoses than non-schizophrenia spectrum disorders. And also in that paper, he did an analysis of the amount of money it costs to treat a child or adolescent with schizophrenia spectrum disorder versus other diagnoses. And you can see that it's about twice as much. So I think this kind of clearly documents a need for these types of services in Hawaii. So to make it a little bit more explicit what our target population is going to be, so we're going to focus on people between the ages of 15 and 24, and we're going to include non-affective psychosis. So when I say non-affective psychosis, I really mean schizophrenia and schizoaffective disorders, schizophreniform, but not mood disorders with psychotic features or substance-induced psychosis. And the reason for that, the reason at this point to exclude mood-induced psychotic disorders or mood disorder with psychotic features is that the evidence base is really for affective psychosis, or I'm sorry, for non-affective psychosis. So it's likely that in a few years or down the road, they'll do studies and find that this program is also effective for mood disorders with psychotic features, but the evidence just isn't there at this point. And for substance-induced mood disorders, there's also not evidence supporting that either. And we're thinking at this point that if someone has a substance-induced psychotic disorder, we would have them get appropriate treatment for that first, and then if they continue to display psychotic features, then they actually would qualify for our study after a period of time. And then, as I mentioned, we're starting on Oahu. And I've talked a little bit about our reasons for this target population already, but the main thing is that we're thinking about this in terms of limited resources. So we have this number of just within KMD system, more people than we're probably going to be able to provide services to. So thinking about how to best use those resources. And there's no theoretical reason why VTC wouldn't work for this sample. You can kind of think about having some of the challenges that come with VTC might be a little bit worse in people with psychosis, but there's actually been a lot of these clinics do use VTC services, but I'm not aware of any clinics that use only VTC. So we're thinking that at this point we're going to limit it to just Oahu. And as I mentioned, we're restricting the age somewhat lower. A lot of the clinics that we reviewed in coming up with this plan accept people from 15 to 30, but we decided to limit it to 24 at this point. Okay, so now we've talked about our plan, I want to talk a little bit about the recovery model and the coordinated specialty care model. So again, moving on to the recovery model. So I think most people are probably familiar with the recovery model in general. With schizophrenia and with first episode psychosis, we're really focusing on this optimism about recovery from schizophrenia, and importance of access and employment and education. And I think the name of our clinic really highlights that, right? So our name being OnTrack Hawaii, we'll talk about helping people get on track with work, school, and relationships to the same extent that anyone would be in those situations. And if we go back to the video that we watched at the very beginning of this, where Ryan was talking about the importance in his recovery of getting back to school and getting his bachelor's degree and then going on to get a master's degree, I think that's something that's really important in this model as well. And one of the things that the people who developed this model say is that that's really kind of one of the most important pieces of this model, if not the most important, is the supported education and employment. And so the recovery model also focuses on reestablishing a sense of identity. So again, this is outside of the sense of identity of being a person with schizophrenia, but being a person just like everyone else, and then going, getting a job and getting back to work and things like that. And along with that comes a goal of having a reduction in stigma. And then finally, one of the key aspects of the recovery model is kind of a shared decision-making model. So incorporating the consumer and the family into the decisions about what type of care someone's going to get, rather than us telling people what kind of treatment they're going to get. So I just want to highlight a little bit how this is different from some other models of treatment and throughout the history of treating people with schizophrenia. The main thing is that it's more of a focus on quality of life than on a reduction of symptoms. So whereas a goal of treatment years ago may have been to make people stop hallucinating, make people stop having delusions, keeping people out of the hospital, things like that, which are still goals that we would want to have. We would want to have people to have fewer symptoms and to stay out of the hospital. But really the main goal is to help people achieve their goals. So to get people back into school, back into work, relationships, to get a job, to get to move out of their parents' house if that's their goal, whatever that might be. And so it takes more of a biopsychosocial approach than a biomedical approach. So the last kind of major thing I want to talk about today is actually kind of some of the nuts and bolts of this coordinated specialty care model. So the coordinated specialty care model incorporates 5 different aspects of treatment. And so this is a chart from the RAISE study that the National Institute of Mental Health put out, looking at where we're thinking about the client being kind of the center of this treatment model, which includes medication and primary care, and also psychotherapy, family education and support, supported education and employment, and case management. So in our clinic, we're going to be providing all of these services kind of within the one single clinic. Our treatment team is going to consist of me as the team leader and Dr. Williams as the prescriber, and then the individual therapy, supported education, and employment and case management is going to be done by clinicians in the Center for Cognitive Behavioral Therapy. So 3 graduate students who are working with me, Erin, Mallory, and Christy, are going to be providing these services. So I wanted to just talk a little bit about why I think this is a good model for providing these services, and why I think it can be beneficial to have students involved in the care of these young people. I think it's important that this model has been successful at UH in the work that Dr. Nakamura and Dr. Miller have done in the past. And it also helps with future dissemination of this model, in that the students that we're training are going to go on to other places, and they're all interested in early intervention and services, and hopefully some of them will even stay in the state of Hawaii to provide these services long term. It provides a built-in practicum training, so one of the things I'm going to talk about is that we're going to have weekly team meetings and supervision that's going to be a little bit more intensive than I think we'd be able to do without students. And also it's important that the clinicians are closer in age to the people that they're going to be providing care to, which will be important for a lot of the older adolescents and young adults who will be coming to our clinic. So we plan to have weekly team meetings, which will involve the team leader and clinicians. There will be a 3-hour practicum. And this will be kind of a practicum supervision that includes didactic training and various things. We plan to partner with the work that Brad and Chuck have been doing at the Center for Cognitive Behavioral Therapy in their child practicum. And we're planning them to overlap somewhat so that we can kind of share resources. And Dr. Williams will also, we're working out the details, will also attend regularly, either by phone or in person, or potentially VTC. So I want to go through a little bit about each of the different 5 aspects of this coordinated specialty care model. So the first is pharmacotherapy. It's a medication. And this will be provided by the Department of Psychiatry and specifically Dr. Williams. And he will see clients at Queens Medical Center. And so when I'm done talking today, we can kind of ask him a few questions about his experience in treating people with psychosis and the medication there. The basic idea is to use a low dose of antipsychotics with younger people, and to kind of increase that dose as necessary, but to keep it as low as possible to provide adequate treatment. Psychotherapy that we'll be providing is going to be from a recovery perspective, based on cognitive behavioral principles. And it's going to emphasize resiliency training, so as the recovery model does. So focusing on what people's strengths are, how you can help them with those strengths to get better, rather than focusing on how to fix problems necessarily. It will include illness and wellness management. So we'll work on, when I say illness management, I mean working on plans for what will happen. For example, what will happen if somebody were to have a relapse, if they were to develop another, have psychosis again. And as part of that kind of shared decision-making model, what they will want to have happen, where they will want, if they need to be hospitalized, where they would want to go, who they would want to be involved in their care, family members, friends, things like that. And then wellness management, there's a lot of interesting research coming out now that things like exercise can be really useful for people in the prodrome and people with early psychosis, in part because of the side effects of the antipsychotic medication, of weight gain and metabolic syndrome and things like that. And we'll also include general coping skills. So this part of the therapy or therapeutic model will be provided mainly by the clinicians in the Department of Psychology. And so these will be people in the clinical studies program. And as I'm sure a lot of people know, we have a kind of strong foundation in cognitive behavioral therapy. The third aspect of the clinic is case management. So we'll assist clients with problem solving, try to address practical problems, coordinate social services across multiple areas of need. And again, this will be provided primarily by the clinicians in the Department of Psychology. And we're hoping to be able to consult in this aspects of things with CAMD and with AMHD to use existing resources where possible. The next part is family education and support. And one of the more robust findings in schizophrenia literature is that the support of family can have a big impact on how people do long-term in long-term prognosis. But it's not always intuitive to think about how this goes, right? So it's not always the parents or the family members who care the most that are able to kind of help people do the best. It's really people who kind of are doing the right kind of things. And so we're coming at this from the angle of that we hope that most, if not all, of our consumers will have family who want to help, and we're really going to try to harness that to get people to get the best support and the best care that they can. And so this will be through this kind of psychoeducation where we help people understand what psychosis is, understand what the treatments are for it, and understand how best to become kind of an active partner in the recovery of the young person who's getting treatment. And so this will be provided in part by me and also by the clinicians at UH. And so I came to the last Evidence-Based Services Committee, and one of the things that I learned there from Project Keliahu was about kind of how to approach families and kind of taking the time to let people make their own decisions about whether or not they want to engage in services, and kind of give people kind of to take the time to just tell people about the services and really listen to them and figure out what they want to do. So based on that, I want to do kind of a cultural formulation interview with everyone who comes in and their family and talk about give them enough information to really make a decision about whether this is something that they think would be right for them and their families. The last aspect of the coordinated specialty care model is supported employment and education. And if we again go back to the video that we watched at the beginning, where Ryan was talking about the importance of school in his recovery. So really, and this is something that may be a little different than other models of treating people with psychosis, in that something that Ryan said in his interview was talking about how it wasn't that stressful, or wasn't kind of exceptionally stressful for him as a person with schizophrenia to go to class and to take finals and things like that, but the idea of wondering whether he could do it and whether as a person with schizophrenia he can accomplish those things was actually stressful to him. So what we want to do is try to empower people and to try to to push people to get back into school, and to do that quickly, right? So instead of waiting until somebody's completely stabilized and 100% better, that we'll be getting them back into school or into work or whatever it is that people are interested in doing. And so our goals here are going to be to help people achieve their expected vocational and educational milestones. So I think with our clinic, we're going to have, and with our partnership with CAMD, we're going to have a lot of people who are still in high school, and a lot of people who are I hope that we'll have a lot of people who are also graduating from high school and going to college, or want to go to one of the community college or even to UH or whatever it might be, and we're really going to help we're really going to try to help them to achieve those goals. And so some of these models have a dedicated person who does nothing but supported education and employment, and do things like working with builds relationships with employers who are hiring people and things like that. So we're hoping to do as much of this as is possible. And because a lot of our clients are expected to be in school, I think that's probably going to be the more fruitful way that we're able to do this than the employment piece. But so we'll have members of our team that work with educators and employers and work with the client. So we'll do a lot of kind of skill-based training with clients and things like that to help them figure out how to solve problems at work, how to solve problems at school, and how to study better, how to do different things related to achieving those goals. We're also hoping that we can work with the adult mental health division and their vocational rehab that they have already set up to use some of those existing resources to really help people as much as possible. We'll try to talk to school counselors in high schools, and we'll talk with counseling centers, educational supports at universities, at community colleges, things like that, to try to work with the existing resources that they have as well. So at UH, Kokua has services for people with disabilities, and we would hope that they would also be willing to work with our population in terms of mental illness. One thing that we're also planning to build on this that isn't officially part of the model is this idea of cognitive remediation, which, if you aren't familiar with that, it's basically training people to improve their memory, improve their executive functioning, and things like that. So they're actually kind of, if you've heard of Lumosity or Luminosity, which is a service that's marketed to everyone. So it's one of those things that everyone can benefit from, and potentially especially people with schizophrenia. So we're thinking about how to build that in to the supported employment education that we're already providing. And we're also thinking of building in social skills training, following Alan Ballack's model of social skills training, which is designed for people with schizophrenia. And there are a couple of reasons why I think this is going to be really useful for our population. One is the obvious thing that it could help with social skills and help people to do better. The other thing is that I think it can be a really useful way to get people in the clinic to kind of buy into the sense of community and support at the clinic. In the first episode clinic that I worked in Maryland before coming to Hawaii, I started a social skills training group there, and it was really a kind of fun experience for the people running the group and also for the clients. And social skills training is based on positive reinforcement. So you have people do role plays and things like that, and then there's a lot of kind of cheering for each other and a lot of support and a lot of laughter and things like that. It's a really fun group to run. So I'm hoping to build that in once we have a large enough client base to run a group. So we've also done a lot of thinking about where our clients are going to come from. And I've mentioned a little bit about CAMD and how there are a lot of young people there who would meet criteria. We're also thinking that we will get referrals from Queens Medical Center as people are released from inpatient stays. Dr. Williams is an attending psychiatrist there, and that clients can be referred at discharge. We also expect to find people from the CAMD system and from AMHD system. I've spoken with some of you about potential referrals from family guidance centers and from places like Kahi Mohala. And so we're really trying to kind of have a broad base of getting referrals to make sure that we're providing as many services as we actually can. So in the one of the things that, as you read about these clinics and people developing clinics, and there are a lot of resources out there available for how to start a clinic like this, one of the things that people talk a lot about is outreach and how to get the word out about these clinics, because it's not something that most people tend to really think about because they're relatively new in a lot of places. So kind of in the spirit of talking about how I've developed or how I've gone about kind of getting things set up for the clinic, I just want to mention a few of the places that I've done talks like this, which is one of the main reasons why I wanted to talk today too, almost to just kind of spread the word. At the Hawaii Psychological Association, I also talked at Grand Rounds, Honolulu Family Guidance Center, and I've spoken with a lot of you about doing consultations or assessments on clients that you currently have that may or may not qualify for the clinic when it opens in the future. But I've done a few psychosis risk assessments, and I'm hoping that that's one thing that I actually really enjoy doing. So if you have any other clients that you think might have psychosis or might not have psychosis and you aren't sure, please refer them to me. I'd be happy to do an assessment. And I'm also doing a research study, doing something really similar, looking at how well those assessments work. In the future, also planning to, as I mentioned, for the supported education and employment, planning to reach out more to university counseling centers and university supports, and also the Department of Education. And if anybody has any ideas about where I could, who I could talk to, or who I could kind of do a presentation to, I'd love to hear that as well. So finally, the kind of the last thing I want to talk about today is how we're going to monitor our clients, how we're going to try to figure out if this clinic is actually working as we expect it to. And we're planning to give several different measures to our clients. The first is a general measure of cognitive functioning called the Measurement and Treatment Research to Improve Cognition in Schizophrenia, or the MATRIX Consensus Cognitive Battery. And so what that is it was designed as a way to measure pharmaceutical trials, to see if pharmaceutical or drugs that were designed to help with cognitive symptoms. So we know that the antipsychotics that we typically use help a lot with positive symptoms. They make delusions and hallucinations go away, but don't necessarily help as much with things like cognitive deficits. And there's been a push in recent years to develop drugs that can actually help with those cognitive symptoms. And the idea was that if we are going to be running these trials, we need to make sure that we're able to adequately measure progress. And so the result of that was this MATRIX Consensus Cognitive Battery that includes 8 different tests that tap different important aspects of cognition. So things like social cognition, executive functioning, working memory, things like that. And we're hoping that our clinic is successful in helping people improve cognitive functioning in addition to things like symptoms, and in addition to things like getting back to work or back into school. So we're planning to give that every 6 months, starting when people first come to the clinic. We'll also we're going to monitor people's symptoms with the positive and negative symptom schedule, which is a rating system of positive and negative symptoms of schizophrenia, and also general symptoms, things like depression and anxiety. So we can really see how people are doing in terms of their symptom functioning. And then finally, we'll use a measure of global functioning, which is really similar to the global assessment of functioning, only we're going to use this one that was tweaked a little bit so that you do separate ratings for social and separate ratings for role scales. So in this case, we would be rating people after talking to them about how they're doing in relationships with other people, for their social scale, how they're getting along with their family, and then also for their role scale, so how they're doing in school, how they're doing in work, or whatever other roles they might have. So we might even have people who have children or are married or have on some of the other range, so that could affect the kind of how they're doing in terms of their roles. We also want to be able to compare the people in our treatment to the rest of the people getting treatment from CAMD. And so we're planning to use some of the things that are regularly administered to other children, like the CAFIS and the Ohio scales for you. So we're hoping that sometime down the road, we could do a similar presentation to this, but actually have data on how our program has done to be able to demonstrate that it has been effective. And finally, I want to thank all of the people who have helped in various ways with this project. There's really been a lot of different voices that have been involved with kind of helping to get all these plans to the point where we're nearly ready to open the clinic. So thank you.